Hey guys, I'm Whitney. We're going to be starting here in just a couple minutes. Clarence is busy letting everybody join in. So if you haven't yet, take a minute to put yourself on Zoom or to put yourself on mute so we can try and limit some of the audio background, and we'll make sure we get a chance to review that one more time. If you guys have any questions while we're kind of getting things started, feel free to use the chat feature. You can send a message specifically to Rehab United Fit Society as opposed to everyone, and that's going to be how we're taking questions today. But there we go. Welcome to Zoom, you guys. I know a lot of people have used Zoom at this point. If you are not on mute right now, please go ahead and take a chance to put yourself on mute so we can limit some of the audio interruptions. If you guys have any questions, like I said earlier, please use the chat feature to send them directly to Rehab United and Fit Society. You can, instead of sending it to everyone, you can send it privately to that option. And that's how we're going to be taking questions. So if you have questions that pop up during the presentation, before we get to the question slide, you can definitely send them over there and we'll try and address some things as they come up. Okay, so I'm gonna take a little minute to introduce our speakers today. I'm Whitney Landis. We also have Beth Ann Soelberg and Sarah Shaw Meach. Mrs. Meach, or Dr. Mrs. Meach, is going through a name change. So a little bit of an ID crisis there, but we're all pretty excited for her. So today we're going to be going over kind of a brief outline. First, we're going to be talking about pelvic floor anatomy and function, and then jumping ahead into bladder health, bowel health, sexual health. I'm going to be speaking in depth on pelvic pain, and then we'll try and wrap it up with a little bit of a hit on physical therapy for pelvic pain and bladder, bowel, and sexual health. Sarah, you got to unmute yourself.
Okay, can everyone hear me now? Okay, so thank you, Whitney, for the intro. Hi, everyone. I'm going to start out the presentation here by orienting you to the pelvic floor. So we are pelvic floor physical therapists. This right here is the pelvic floor. This is what we specialize in. And so I'm going to talk to you about where it is, what it does, why you should care about it, and yeah. So I'm really passionate about it. I believe it's probably one of the most neglected muscle groups when it comes to fitness and rehab, which is pretty interesting to me because it serves some pretty important functions, which I'll get into in just a second. But right here on this slide is a nice view of the pelvic floor. It's a three-layer muscle group that lays like a hammock at the bottom of the torso. So if you were laying on the floor looking up at your girlfriend's butt, this is the image you would see if you had X-ray and MRI vision, right? You can see the pelvic floor muscles here, and they kind of wrap into the hips here. They attach to the tailbone, which influences the low back too. And so I can show you on this next slide. Oh, geez. Okay, here we go. Here's a nice image showing the male and female pelvic floors side by side. Left is male, right is female. Yes, males have pelvic floors too. You would be surprised how many questions I get about that. But they have very similar muscular structures. We treat men and women and everything in between, of course. And so you can see here very similar muscular structures, just a few differences, but definitely more similarities than differences. On this next slide, here is a great image showing some of the similarities in the female and male sexual organs. They derive from the same embryonic tissues and serve similar functions. On the left is the elusive clitoris, and it is mostly internal. The little pink part is the only external part, which is why it's so difficult to find. And obviously on the right is the penis, which is mainly external. Interestingly, the clitoris is 10 centimeters in length and is very hard to find because it's mostly internal there. So all of the purple part, all of that blue part, that's all deep within the pelvic floor there. Here's another slide showing a visual of the similarities between the male and female superficial anatomy. So basically it's the same jello, different molds, lots of similarities here. And here's a little bit more detailed of a slide here. Just to orient you, the female on the right is laying on her back and the male on the left is laying on his stomach. Again, side by side, the important part to pay attention to here is the red, blue, and yellow lines, so skinny little lines there. The red and blue lines are arteries and veins, and the yellow structures are nerves. So the pelvis is really densely packed with blood vessels and nerves, owing to the many different functions of the pelvic floor, which I will get into right now. So this brings me to the many functions of the pelvic floor. As you can imagine, life becomes very unpleasant if any of these functions go wrong. And that's exactly the problems that we treat as pelvic floor PTs. So for example, the pelvic floor is in charge of sphincteric control. So this is the ability for you to control your bowels and your bladder. We see lots of patients for incontinence, which is incredibly unpleasant. And it's also the #1 reason older folks are sent to nursing homes. Another function of the pelvic floor is support. So the pelvic floor is responsible for holding up the pelvic organs. If this goes wrong, sometimes we see pelvic organ prolapse, where the organs begin to descend through the vaginal opening, which is also really unpleasant. Also stability. This muscle group is responsible for keeping the pelvic ring stable. And some of the muscles, like we saw before, go into the hips too, and they're hip rotators. So if this function goes wrong, we often see pelvic pain, SI joint pain, pubic pain, groin, low back pain, you name it. We also can see some pelvic asymmetries with alignment there too. Also, the pelvic floor is responsible for pumping fluids out of the lower extremities. So it works as a skeletal muscle pump to bring fluid like blood and lymphatic fluid from the lower extremities back up to the heart. If something goes wrong here, it can cause pelvic congestion, which causes pain and pressure and sometimes varicosities through the pelvic floor as well. And then obviously sexual function as well. These muscles are responsible for achieving and maintaining erection and orgasm too. So I wanted to take you, don't worry, it's not really a quiz. It's just an activity that we do with some of our patients here. So what I'm gonna have you guys do is do a little check-in on your pelvic floors. So there's gonna be an anonymous poll coming up here. So you can answer the questions honestly. I believe there's gonna be a poll that pops up. But we're gonna go through 3 activities here. We haven't told you what to expect, what's supposed to happen, so we'll see what our pelvic floors are doing to start, and then we'll go over the answers afterwards. So what I want you all to do is go ahead and sit with your feet on the floor. I want you to sit square on your bottom, and if you want, for the full effect, you can even sit on one of your hands. And so right now you're actually sitting on your pelvic floor, and I'm gonna have you go through a couple of activities and then answer some questions about them. So, to start off, while sitting on your hands, what happens when you try to contract your pelvic floor? So what I mean by this is, what if you tried to stop the flow of urine, hold back gas, or close the opening? Do you feel the pelvic floor lifting up? Do you feel it bulging down, or can you not feel anything at all? You can go ahead and answer the question here. Do I get to answer the question? Okay.
Gonna throw off the data.
Oh no, okay. Well, I don't know. Clarence, can we see the answers right away or at the end?
Yeah, I'm just waiting to give everybody a chance. We've got about 26 out of 30 people.
Perfect.
So I'm gonna give it about
Answer honestly.
seconds.
We'll talk about it after. It's anonymous.
All right, I'm gonna go ahead and end it here.
Okay, cool. Cool. You felt it lift up. Okay, I'm not going to talk about the answers until we do the next two. So we'll move on to the next question. If you're sitting on your hand again, do that same stance. You're sitting square on your bottom. Sit on your hand. What happens if you try to lengthen your pelvic floor? So if you were trying to bear down like you're trying to initiate a bowel movement, answer the questions. Do you feel it lift up? Does it bulge downward, or are you lost? No wrong answer. That's a lie, there is wrong answer. No pressure. We'll give you a couple minutes to answer that. Oh, yeah, I have to answer.
I'll give it just another 10 seconds, guys.
Thanks.
All right, let's take a look.
Perfect, looks good. And for the last one, same stance here. I want you to feel what your pelvic floor is doing here. But what I want you to do is see what happens when you take a deep breath in and then exhale slowly. Do you feel your pelvic floor lift when you inhale and lengthen when you exhale? Do you feel your pelvic floor lengthen when you inhale and lift when you exhale? Or are you still lost? Try it a couple times. So these are some of the things we go over in pelvic floor PTs for people to just become a little bit more mindful about what their pelvic floors are supposed to be doing and when they're supposed to be doing it. And then we'll go over the answers in just a second.
Just gonna give it like a couple more seconds. Got a few people. All right.
Okay, that was a hard one. That one's really subtle. Okay, so let's go through the answers real quick. So number one, when you contract your pelvic floor, you should have felt things lift up off the surface you're sitting on. So if you didn't, that's okay. It's possible you just need to practice a couple more times. Or maybe you felt a bulge downward. Maybe you felt nothing at all. There could be some weakness or incoordination going on there. For number two, when you lengthen the pelvic floor or bear down, you should have felt it bulge down into the surface you're sitting on. So again, if you didn't feel anything or you felt the opposite, it might be some incoordination or weakness going on. Give it a few more tries and see if you can switch it. And then for number three, this is really super subtle, but I like it because it really shows the relationship between the respiratory system and the pelvic floor. So if you have more questions about that, ask us in the chat and we'll get into it. But when you take a big deep breath in, the diaphragm underneath the lungs, it drops. So that increases the pressure in the abdomen, causing the pelvic floor to gently lengthen and bulge down. And then when you exhale, the diaphragm rises up again, decreasing the pressure in the abdomen, so the pelvic floor should have lifted gently. So that's super subtle. Try it a couple more times, see if you can feel it. There's any questions about that, let us know at the end. We'd be happy to elaborate on that, but that's just a little sneak peek into what we do in pelvic floor PT to help our patients check in, see if their pelvic floor is doing what they're supposed to do when it's supposed to be doing it. And so that segues nicely actually into what Beth Ann will talk to us about bladder, bowel, and sexual function. So she can take it away.
All right, so we are going to move on with like what Sarah talked about. There we go, a little tricky. I actually love talking about this. and this is probably why I'm into this field, but even just like talking about bladder and bowel norms, it just so surprises me on how us as humans, sometimes we don't even know what we should be doing with our bowel and bladder. So that's what we're going to be talking about here. And so what we've kind of talked about already is common things that we treat as pelvic floor physical therapists is the urinary system. So that can include things from urinary incontinence, frequency, urgency, and sometimes common symptoms that come with that is kind of pain with urination and difficulty emptying a bladder. So I'm going to briefly go over some good bladder habits. So to introduce this, I want you to reflect. How many times did you use the bathroom today? Was it 3 times? Was it 10 times? How many was it? When you used the bathroom then, how long were you peeing for? Have you ever thought about that? How long was the time between each of your bathroom visits? Was it an hour? Was it, oh wow, I can't remember, it was like 5 hours ago. When you did go to the bathroom, how long did you pee for? Once again, those are things that we don't usually think about, but can lead to maybe, is this how it should be? So provided on the slide is some what we consider bladder norms. So voiding 5 to 7 times per day. So that's roughly every 2 to 4 hours. A lot of times people 1 or 2, is it normal for me to get up in the middle of the night? Kind of depends on your situation, but normally 0 to 2 times. As we age, it does get more normal for us to pee at night, and especially when you are pregnant. Dropping down to how long did I pee for? I love this fact. It's just a kind of a generalized fact. So it's not doctrine, but it's a good kind of indication of, was my bladder full? And I call it the 8 seconds of Mississippi, 1 Mississippi, 2 Mississippi, 3 Mississippi. So if you're able to pee for 8 seconds of Mississippi, that kind of is a good indication that your bladder was full. And that leads to our next one is, are we getting adequate hydration to have good bladder health? So roughly what you can do is take your weight and divide it in half, and that's how much you should be having fluid-wise during the day. All right, some other stuff. So if you're like, I don't know if that was actually where I'm at with my bladder or with my voiding habits. So some key things that we can help with that is actually sit on the toilet. It would surprise you of how many times we may have fear when we go out in public. Ooh, I'm not quite sure who is sat on this toilet, so we fear sitting on the toilet, and that can lead to some problems down the road of not relaxing our pelvic floor. So putting something down on there, so you actually sit on the toilet. Also, when we use the bathroom, give yourself some time. Don't feel like you have to rush or push through it. And that leads to some of those professions, you're out there, the moms, the nurses, the teachers that like got kids pounding on the door. I gotta get in, I gotta see ya, or I've gotta quickly get back to someone. As like I mentioned before, keep hydrated. So you could take your weight and divide it in half, or you can take it, or if you want specific numbers, 6 to 8 cups a day or 64 ounces. Avoiding bladder irritants. Those can be ranging from anything that involves like coffee or caffeinated products, soda, pop, I guess wherever you're from in the US. And if you have problems with those, you can reduce it or dilute it. Big thing that we also see is avoiding doing a just in case pee. That can lead to other unhealthy bladder habits as well. And then lastly, another tip that we go through with a lot of our patients that we see is called the potty matrix. That can be useful in helping empty the bladder. Just going to briefly talk about it. This can involve just doing kind of like a circular motion while you're sitting on the toilet, or even standing back up, sitting back down, and trying to void some more. Can help just shift things bladder and help you empty that bladder completely. All right, moving on to bowels. I love my little picture that I found here, our happy little colon here, because our bowels should be happy. So going over bowels is if we refer back to what Sarah taught us with our anatomy, pelvic floor doesn't just involve voiding, which is what we often think of. Oh, I've got urinary incontinence, it's my pelvic floor. My bowels are completely unrelated to that. wrong. As you can tell, pelvic floor goes from front to back, so it involves also rectum or bowels. So just like the bladder, there are norms of having bowel movements. So 0-3 times per day, greater than 3 times a week. Roughly, we really want to see at least 1 bowel movement a day. Along with that, when you are having a bowel, no leaking, no pain or straining with that, as well as bleeding, can lead to or might be indicators of something else going on. Also making sure that you are spending an adequate amount of time, but not too long on the toilet. If you're sitting there for, a half hour trying to poop, there might be other things that we need to look at to help with that. And then things that I'm going to talk about with our bowels is consistency. Bowels love consistency. So something that we talk about is when we have bowel movements, our stool should be like a soft serve. And I'm gonna refer to the next slide. Right there is our lovely Bristol stool chart. Now, if you've never heard of this, that's okay, but I love this little animation. Once again, if you notice that each of those little stools have faces on them, if you look at them closely, some of them have frowny faces, some of them have like really angry faces, and then some of them have really happy faces. So as you can tell, the best one on there is type 4. That's what we're aiming for. So ways to help with that is to stay hydrated. So just like bladder, we need to stay hydrated. Having a good diet, so a good adequate amount of fiber. And then if we are still seeing problems with that, looking at our diet specifically and seeing there's any sensitivities that way that we can kind of go down that rabbit hole and figure out. Another important thing is exercise as well, because that helps things move along. Position yourself for success, meaning when you're actually having a bowel movement, you need to look at your ergonomics, which will go on in the next slide. I'll get to that, but we'll go into a little bit more. And then once again, consistency. Bowels love consistency. If you think back about when you have your bowel movements, you should see them happening at the same time every day. Leading into that, bowels love when we have our same foods and at the same time every day. So like I talked about, positioning is really important. So this is like a good indication, like a good education piece. So let's do this a little interactive. If you're sitting down or if you're standing, go ahead and sit down. And I want you to take a second and look at how your feet, your knees are in relation to your hips. So both feet should be planted on the ground. Where are your knees in relation to your hips? Are they at the level of your hips? Are they below? Are they above? As you can tell from this picture, the one on the left is their equal level of the hips. And then on the one on the right, they have a little stool underneath their feet, props it up. As you can tell from the picture down below, when we prop up our feet, it allows for those pelvic floor muscles to relax or allow a better bowel movement. Other things that you can do, what Sarah talked about too, is our breathing mechanics. That helps with bowel movements, so we're not having to push or strain. Other things that we can do to help with bowel movements is called an ILU massage. So if you're experiencing a lot of like bloating or difficulty digesting, just like if you were to help a baby that's really, really gassy and you rub their tummy, you can do the same thing for you, and I call it the ILU massage. So just like this picture shows, you start at that purple arrow, you start on the right side of your hip, and you work with small little J stroke, and you work up towards making that I. And after you do that, you start back over in that same position. You make that U, or the L, excuse me, you make that L. You do that same thing, and then you repeat making that U. As you can tell, it follows your colon, so it helps move things along. It helps stimulate it along and helps decrease kind of that gassing, bloating feeling, and helps with better bowel movement that way. Lastly, I'm not going to spend a whole lot of time because we're going to kind of give this kind of pelvic pain section to Whitney, but I did want to express that sexual health with our pelvic floor is so important for our physical health. In the PT world, we consider our sexual health, or we consider an ADL. For those that don't know, ADL is an acronym for Activities of Daily Living. We consider it a very essential thing in the pelvic or in the PT world that you need to be able to do throughout your daily life. And so for us, sexual health is just as important for that. Just some tips like I've provided with bowels, just some tips for sexual health, what we kind of do with our patients or suggest as a way to help if there's some struggle is before engaging any type of intercourse, do a little bit before care. If you need to help yourself relax, find something that helps you do that. Make sure that there's adequate time for foreplay because that's super important for relaxation and helping that pelvic floor relax. If penetration is not possible without having pain, have a plan B. Figure out what a plan B is between you and your significant other. If you do have pain with a certain position, try different positions. Many different positions allow better control for whichever partner, and that can help decrease a lot of that pelvic pain. Lube. This one is huge. If you need to use it, especially during times of aspects of our life, especially for women when we experience different changes in our hormones, which can happen during pregnancy. It can happen postpartum, especially breastfeeding, as well as we get into our menopause stage. So if you have any concerns that way, definitely bring it up with your OB and ask questions with that to help with it. And then lastly, the thing is aftercare. Super important as well, just as much as anything else, aftercare. If there's any pain, find something that helps you relax, whether that's a massage or a hot bath. Do something to help control that pain. And then lastly, I threw on this picture. Many people don't know what this is. It's called an ONA. It's something also to help address any pelvic pain during intercourse. It's a great product that helps with the deep penetration and help prevent pelvic pain during intercourse for the woman. And I'm now going to turn over, kind of segue over into Whitney. Whitney, the time is yours.
Thank you so much. And I apologize, I am losing my voice a little bit. So bear with me if anybody's having a hard time with my voice. So sneaking ahead, notice we said that pain wasn't normal. What is pelvic pain? We've kind of reviewed some of the anatomy that's pertinent to the area, but let's talk about what pelvic pain actually is. It's defined as being pain in the lower abdomen or pelvic region, and it may be in the front of the body or the back of the body, generally not along the sides, like towards the hips, but it can be on either side of the pelvis. Within that kind of general pain category, we also have acute onset, which is a more recent onset. Typically, those are related to medical conditions that warrant a visit to your physician's office. Urinary tract infections, sexually transmitted diseases, appendicitis, ectopic pregnancy, cancer. Those are not things that physical therapists are going to be able to help you with in their emergent state, but sometimes the lasting pain associated with those things or dysfunctions related to them are things that physical therapy can help with. And then chronic pain, that means pain that's been there for more than 3 to 6 months. And it's, again, really important that you see a physician to rule out some of the conditions that can require further medical intervention. But some of the things that fall under that category are things like endometriosis, interstitial cystitis, or painful bladder syndrome, and prostatitis. Those are kind of pain conditions within the pelvic region that, again, benefit from seeing a physician for diagnosis and treatment. But those are things that physical therapy can help to address some of the symptoms related to it. So today, I'm not going to spend a whole lot of time talking about visceral or organ-based sources of pain, just because those are kind of out of the scope of our practice act as physical therapists, but know that there are things that can contribute to abdominal and pelvic pain. So within chronic pain, and this is a really big thing with chronic pain, I'm not talking specifically about pelvic pain right now. This is chronic low back pain, chronic knee pain. There's this thing called central sensitization, which is where your central nervous system becomes more sensitive to the continuation of those pain signals being sent from the body up to the brain. And it's a big challenge, because it's like that dimmer switch for an amplifier, where originally we're getting hit with a few, hey, this is uncomfortable, hey, this is painful. If something doesn't happen to change that, or even sometimes an acute pathology has been treated, gone, but the body still has a memory for that pain, and the body's still sending those pain signals, even though the pathology that originated the pain signals is no longer there. That's one thing that we see with like urinary tract infections, where you still feel the urgency to go to the bathroom, the bladder discomfort, sometimes that pain, the burning sensation when you're peeing. That can lead into a few different conditions. One of them is hyperalgesia, which is where a mild to moderate painful stimuli feels extremely painful. So hyper meaning increased in sensation. So it's a normally painful stimuli. I stub my toe, it hurts ordinarily, but in hyperalgesia, I stub my toe and I feel like the world is coming to an end. I'd rather cut off my foot than deal with the pain associated with stubbing my toe. Or allodynia, which is when a normally non-painful stimuli feels painful. So this is really problematic for people, because it's very polite in society to wear undergarments and pants and things to cover our genitals. So if you have allodynia in the pelvic region, wearing pants can be uncomfortable. So women have the option to wear skirts and dresses. Men, fortunately, can wear kind of looser garments, but it can be very debilitating to not feel like you can do certain things, or to have that kind of constant stimulation. So for women, that's vulvodynia or vestibulodynia, a heightened nerve firing related to the nerves in the pelvis, or scrotodynia in men. As we all know, men have pelvic floors as well. One of the other things that can occur with that is called cortical smudging, which is where we lose the ability to localize sensation. So instead of this spot right here hurts, my entire hand hurts. And if it goes on long enough, it's not just my entire hand, it may be my entire arm that hurts. So what had started out as appendicitis and an appendectomy, you've got this tiny little scar, it's no longer just this right lower quadrant pain. Now it feels like I have an elephant sitting on the right-hand side of my body if my nerves are overly sensitized. Cortical smudging is also highly involved with emotion. The way that the signals go through our brain has a big impact on emotion and what that pain means to us, because pain is just a sensation. It's not something that's really directly tied into the amount of damage. It is a sensation related to possible or potential threat of injury. So there's not a certain thing that says if you have this amount of pain, you're going to have this amount of muscle or tissue damage. And that's one of the things that's really hard with pain, is because pain is there to protect us. It's for us to say, oh, I stepped on that, it was hot, I need to get away from it. It's there to protect our body. But when we have this chronic pain, we don't know how to respond to that. And that can be really confusing for the body and the brain. And then we also have musculoskeletal pain. So this is pain that's related to muscle, tendon, fascia, ligament, bone, or joint dysfunction. The sacroiliac joints, the pubic symphysis, our hip joints, our lumbar spine are all very closely related to pelvic floor function, and can cause issues there. I swear one of these days I'll figure out how to advance the slides. So talking about some of the nerve function, this is just a nice graphic that shows some of the nerves. So if we end up with a nerve entrapment or sensitivity along the nerves, you can see where that can contribute to pelvic pain. And it can be pain in different regions, depending on which nerve is involved. And then again, looking more broadly at the torso, because sometimes with like a C-section scar, you can have an involvement of the iliohypogastric nerve. For women that spend a lot of time in stirrups during a pushing phase of labor and delivery, the femoral cutaneous nerve can be impinged and contribute to pain along the anterior hip region. Ilioinguinal nerve can be involved with people that have hernia surgeries or that spend a lot of time in a deep squat, like catchers for baseball. So coming back and taking a nice little visual again, looking at some of those nerves. So all the yellow structures in the pelvis here are nerves. So if my muscles are really tense and really tight and irritated, they're going to impede some of that nerve function and can actually give us nerve pain in addition to just having muscular pain. So a lot of times pelvic pain is a combination of different things. It is rarely just one thing. It may even start as one thing and then lead into something else. And then chronic pain and stress. Again, this is another one of those things that is non-specific to pelvic pain and more specific to chronic pain in general, but has some very specific implications for pelvic pain. When we look at repeated exposure to stressful events, that's going to increase our sympathetic nervous system drive. It's going to shift us towards that fight or flight stimulus. So if we are constantly living in this kind of up and agitated state, it makes it really hard for our body to actually rest, digest, calm down, and let our body kind of live in the way that it's supposed to. One of the hard parts with that is sexual arousal can simulate and stimulate the same fight or flight pathway. So we think about maybe feeling a little bit amorous with our partner and we're going to flush, our heart rate's going to increase, we're going to be turned on. And the hard part there is that it can feed into a PTSD type response for somebody that has a traumatic background and make them really shy away from wanting to go down that road. And emotion can really change how we experience pain. People that experience pain with a negative emotion, when they feel that pain, it has a very negative consequence in the future. So somebody who may have had a sexual assault may remember their pelvic pain at that time as being a very negative thing to experience. And it means something a little bit different to them to a woman who's giving birth and has a perineal laceration or a tear through the musculature in the pelvic floor when she's giving birth to her child. She may not care that that pain that she may have felt is like totally forgotten because she has this amazing, great thing at the end of that experience. And so if she gets that pain again, it doesn't mean the same thing to her as it does to somebody with a negative experience associated with it. So one of the things we didn't really mention earlier is that biopsychosocial model is super important for addressing pelvic pain. So making sure that you've got a good psychologist on hand or counselor to help deal with some of the emotion that goes along with these things is really, really important. And then again, talking about self-fulfilling prophecy, if sex for you is painful, and it has been for a long time, even if you're making strides and improving things and changing things, if you get back into the bedroom or wherever you're deciding to be intimate and you're expecting it to be painful, there's the expectation of pain where muscles are guarded and we're kind of shied away from something. It can be a self-fulfilling prophecy, whereas opposed to our muscles being relaxed and we're into it and excited for it, we're sitting here all tight and clenched, and that can make the openings or friction a little bit more difficult. The other thing to consider with chronic pain is the sensitivity of the nervous system. So you can sometimes feel things that you shouldn't ordinarily feel, and they can be uncomfortable and painful sometimes, which can lead into kind of a hypervigilance of bodily functions. So ordinarily we go bladder full, cool, gotta go to the bathroom. If somebody has pain associated with bladder filling, the stretch of the detrusor muscle, the pressure on the nerves around the bladder, or the pressure that it puts on the pelvic floor muscles, it's not just, hey, my bladder's full, I need to go empty it. It's, oh my God, my bladder's gonna rupture, this is terrible. And it can lead into some of that catastrophizing, which again, is something for mental health to help address from that perspective. But they're very real things that our body is experiencing. We touched on it a little bit earlier with painful intercourse, also known clinically as dyspareunia. 30% of women and 7% of men reported pain during vaginal intercourse. 72% of women and 15% of men reported pain during anal intercourse. Most of them did not want to tell their partner. So you know what that means? A lot of people are having pain when they shouldn't be having pain. And it makes it a little bit more challenging to come back to what Beth Ann was talking about with being able to change position. If the position that you're in isn't a good option for you, change. This is coming back to, if you're not speaking up and talking about your pain with something, you're sensitizing that pain pathway over and over and over again. It's that old joke, it hurts when I poke myself in the eye. Well, stop poking yourself in the eye. Sometimes you have to break a cycle in order to let the body kind of heal and let the nervous system calm down, so that when you're ready to resume an activity, you're coming at it with a fresh atmosphere for it. Again, things that are helpful with painful intercourse are foreplay, pelvic floor play, all those things that are really helpful to get the mind and the body in the same connection, where we're involved in the moment and we're able to put a better association with some of what's going on sensation wise, going, yes, I feel pressure, it's not pain. I feel tension, but it's okay, I'm not doing any damage. Water-based lubricant is a pretty much recommendation that we make for anybody that has pain with intercourse, because that friction can be problematic. Think about inhaling with exertion, as we talked about with Sarah's little poll there. When we do that nice big belly breath, that diaphragmatic breathing, diaphragm drops down, helps to relax the pelvic floor. So instead of sitting there all tense and tight and going, oh God, it's gonna hurt, you can take control and plan on how you're going to help your body relax. That diaphragmatic breathing actually helps us to stimulate the parasympathetic nervous system as well, helps to reduce our heart rate, and just kind of brings down a more calm setting for us. If those things aren't helping, plan an alternative activity like she talked about. And then postcoital care, this is your aftercare, the same as if you'd had a strenuous workout or ran a race and you were having some discomfort afterwards, you would take care of your body. There are things that we can do to help with pelvic pain after intercourse, whether it's using heat to help with muscle tension or cramping, cold to help with vasoconstriction. It's kind of that throbbing, aching discomfort, and some gentle stretching, coming back to some of the breathing, even coming into a supported bridge pose and letting some of that blood flow drain out of the pelvis can be really helpful for getting yourself out of any sort of discomfort that you're having. Hormonal influence. So male and female are a little bit different with the hormones that they have on board, and that can change how the body responds to pain. Interestingly, low testosterone in men increases pain sensitivity. Chronic opioid use reduces testosterone, so it's going to increase your pain sensitivity. So you're taking pain meds because you're in pain, but it's going to change how your body responds to pain. Interestingly enough, men are less sensitive to acute pain. So that appendicitis that they may put off going to the doctor for until their appendix ruptures and causes all kinds of less happy stuff. And then their coping mechanism is behavioral distraction. That basically means going and doing something else so that they're not focusing on the pain, which sounds about right. For females, our pain tolerance can vary a lot around our hormonal cycle. Our pain threshold is highest with high estrogen and throughout pregnancy, peaking at the time of delivery. Go figure, you're going to try and push a watermelon out of something the size of a lemon. It'd be great if it didn't hurt quite so much. And then our lower thresholds is right before our period, which unfortunately is when we're getting all of our PMS and our cramps and everything hurts anyway. Again, not surprisingly, our coping mechanisms tends to be social support. So talking to other people about having pain or what we do to cope with our pain. Again, a little bit more specific to some of the pain conditions affecting females versus males. women are more prone to stress incontinence or urinary tract infections because of the shortened urethra. Makes it a little bit easier for stuff to get on in there or stuff to come on out of there. Premenstrual syndrome, or PMS, is associated with abdominal pain, can be back pain in some people, cramping, breast tenderness, mild and temporary constipation or diarrhea, depending on what's going on. There are some disorders that make those symptoms more significant and life disrupting. And those are things that physical therapy can help to address some of the symptoms associated with it, but it will not change the actual physiology of what's going on. Pregnancy, diastasis, stress incontinence. The bigger baby gets, the less room there is for bladder and the more pressure there is. Urinary urgency and frequency, pelvic girdle, and low back pain because of some of the hormone changes and the postural changes. And then constipation during pregnancy is real unfortunate. With some of the hormone shifts, our GI system slows down. And unfortunately, the constipation bearing down can lead to hemorrhoids, which are more prone during that time anyway because of the weight of the uterus on the pelvic floor. And then postpartum care, scar care, whether it's a C-section or a perineal tear, both of those benefit from being mobilized and making sure that as you move through that scar tissue, it moves and expands and doesn't pinch or bind or cause pain. And also with assisting with your return to prior level of function, making sure that you're not having any compensations related to the pelvic floor. So making sure that you're not leaking any urine as you resume your exercising, making sure that you're not having any pain, feeling like your pelvic organs are going to fall out, are kind of big things. And then peri and postmenopausal, there's a hormone shift that can lead to something called vaginal atrophy. When the female body is low in estrogen, the vaginal tissues can be thin and more sensitive, more prone to friction, and can cause some bleeding and irritation. So imagine having windburn lips, what it feels like when you touch them, when you're eating. It can have that effect on the vaginal tissue. So things like intercourse with all that friction can be irritating, cause micro trauma, and can irritate the pelvic floor muscles, as well as a loss of pelvic muscle bulk and strength without their normal hormone mode. And then for men, circumcision scars can cause pain with intercourse or masturbation, which is really unfortunate. Those things are not supposed to be painful for men. Men also have a prostate that women do not. Hypertrophy can restrict the urethra and cause some downwards pressure on the pelvic floor musculature and contribute to pelvic floor muscle pain. Prostate resection also increases the risk for stress incontinence. So if that's something that is in your future potentially, it's definitely worth getting a check-in with a pelvic floor PT to figure out what your current strategies are, what your current strength is, so that you know what your likelihood of things is coming out of surgery. And then erectile dysfunction. There are many things that can cause erectile dysfunction. One of them that is within the scope of physical therapy to help address is muscular tension limiting blood flow. So if we think about an erection, it's big, strong, and engorged with blood. If the muscles are too tight to allow blood flow to come into the penis the way it's supposed to, the erection's not going to be what it may have been at one point. Men are also more prone to hernias. They tend to choose strategies that involve an increase in intra-abdominal pressure and that continued bearing and straining down. Like we talked about, women have higher rates of stress incontinence. Pelvic floor has some give to it, and the shorter urethra allows them to leak urine. For men, their compensation with the increase in intra-abdominal pressure is that it tends to cause hernias for them, whether it's diastasis, the alien sticking out of their belly, or the inguinal hernias. And then levator myalgia is a term that refers to pain in the levator ani group or the pelvic floor muscle group. And it can refer pain to the low back. So low back pain in men is much, much, much more prevalent than pelvic pain. And I'm curious how much of the back pain is actually pelvic floor dysfunction that is not thought of as being pelvic floor dysfunction because of its location. And then kind of somewhere in the middle, our transgender care or non-gender conforming care. Pelvic pain, sexual and physical abuse, and trauma are the most prevalent in this population. And pelvic health PT can help mitigate some of the pain responses and address some musculoskeletal or nerve system issues related to that. Special considerations with this population are male to female gender affirmation surgery creates a new opening in the pelvic floor that wasn't there previously, and that can lead to pain with insertion. And then female to male, the testosterone-induced vaginal thinning, similar to the vaginal atrophy that can be seen with our peri and postmenopausal females. So making sure that they have access to care that understands the things that may be going on with the change in the hormones are pretty important things. And then knowing that physical therapy can help address some of the scarring issues with the gender affirmation surgeries. At this point, I'm going to turn it back over to Sarah to wrap it up.
Okay, hello again. So just to wrap up, I just want to take a step back and explain a little bit about what you might expect in pelvic floor PT. So next, there we go. So we usually get lots of apprehensive questions about exactly what we do as pelvic floor PTs. So I wanted to give you an idea here. We don't just poke and prod at people. We first look at how people are moving. So first we look at how you're walking, how you're moving. We look at your posture, range of motion, strength. And the reason we do all of this is because the pelvic floor never works in isolation. It works with all of its buddies, all of its surrounding muscle groups. So we do take a bit of a more holistic approach where we kind of zoom out with our evaluations and make sure we aren't missing any surrounding weak links that we can address. We also can do an optional and obviously consensual pelvic floor assessment. We don't use any speculum or stirrups for these. We just use one finger to feel the pelvic floor muscles either vaginally or rectally. And what we're looking for is we're just assessing muscle quality, sensitivity, strength, tone, and coordination just to kind of guide our care. But from there, we're able to really determine a plan of care, which of course is customized and individualized with each patient. We listen to what the patient has been telling us. We take what we've observed with our objective assessments, and then we could come up with like a really awesome customized treatment. That usually includes a combination of hands-on treatment and exercises, and of course, a ton of education. And so that's what we do. From there, we want to open it up to some questions. Again, there's no weird questions here. We spend our days talking about poop, pee, and sex. So you can ask anonymously if you want by directing your questions to the Rehab United Fit Society dropdown, if I'm not mistaken, in the chat function. And we'll go ahead and take some questions.
Oh, I have some questions. Hi, my name is Ava. This was under Beth Ann when you were doing, what was it, bladder? On the, it was the bladder norms. And there was one that said avoid the just in case. I think I'm guilty of that, you know, like when I'm going on an errand or I'm just going out and about. So especially now with, you know, what's happening and we're trying not to kind of, I guess, have any kind of physical touch with anything. How would you navigate, you know, when you're going outdoors now or when you're going in public, how would you navigate something like that? I mean, is it something like we would just try to use the bathroom at home, or, I mean, what do you recommend?
Do you guys want me to answer this?
Go for it.
So, I mean, yeah, during this pandemic, certainly we can have kind of some of those tendencies to want to avoid bathrooms. And sometimes you go to places and the bathrooms are closed down. First and foremost, I'm going to go back to what I originally said, avoid the just in case. So if you do and you're out and about and you do see a public restroom, it goes back to what they've been teaching us, wash your hands. Go to the bathroom, don't touch your face, just use the bathroom, wash your hands afterwards. That will take care of any kind of germs that will do it, especially washing your hands for what they've recommended on the CDC, using soap. If you can't, use hand sanitizer, so make sure that you have that with you. So answering the question to avoiding public bathrooms, I would still use them, just wash your hands. But if they're not available and you know that they're not going to be available, yeah, go for it. It's just not making it a habit every single time of like, oh, well, we're going to go, I don't know, do some sort of errand. I got to do it just in case. And so every single time you go out, you're like, oh, I should just pee just in case. Those are kind of the things that we want to avoid. Now, if you know that you're leaving, you're like, oh, well, it has been like at least 2 hours. Yeah, sure, that's totally fine. But it's those, oh, I just went 30 minutes ago, but we're leaving again. That's where I kind of like start wondering too. And I know that Whitney looks like she wants to jump in and say something too. You've got to unmute yourself.
So I think it depends on, I'm unmuted now, okay. I think it depends on how long are you gonna be gone? Are you running to the post office at the end of the street? Or are you going to grocery stop by Home Depot, pick something up from Target with curbside delivery, and then come back home? I feel like it's one of those risk reward type scenarios. How often are you peeing right now? How long are you going to be gone? What happens if you can't get to the restroom within your normal voiding time? Is it just uncomfortable for you, or do you need to change your clothing if you can't get to the restroom? So I think it's a hard thing for anybody to necessarily tell somebody specifically, so much as give some guidance and some recommendations.
Perfect. Thanks, guys. I'm going to go to the next question. Do you offer telehealth for pelvic floor visits, and how does that work? Does insurance cover it?
I will hop on that one for the most part, since I'm kind of here and talking anyway. So yes, it depends on your insurance, but telehealth is covered right now, I want to say, through most of our insurances. We don't have any front office staff on.
No, but I could probably jump on that. Because insurance varies so differently, we recommend just reaching out, and our front office can look into that with your insurance and get information that is specific to your provider. All right, so the next question, is there an outcome difference for internal versus external pelvic floor muscle release?
Anybody want to take that, or you want me to take it?
Go for it.
Okay. Internal versus external it depends. I think that's probably the big theme for a lot of things. To me, the gold standard, what I would prefer to do is internal, because I am addressing it specifically. So I know we've got some physical therapists on with us. So if you're treating TMJ, if I'm treating TMJ and I'm just treating externally as opposed to intraorally, it's going to be a different outcome. I'm able to get to the primarily affected muscles a lot more specifically internally than I am externally. However, there is still a lot of benefit to doing external treatment that can allow us to do internal treatment or address things to a point that symptom management and symptom level is significantly better. So there's benefits to doing each of them. External, we can do relatively quickly if we're seeing somebody's ortho patient and they're not sure, maybe they have a pelvic floor dysfunction going on. We can come in and check the obturator internist externally by coming in towards their sit bone and see if they have a tender spot there. If they do, it's a pretty good likelihood that if we check internally, it's going to be more tender and give us a little bit better information. For somebody, if they don't want to remove their clothing, if they have a trauma history past and it's not something that they're comfortable with, then we're going to work within whatever they're able to allow us to help them with. So treating externally is a good option for us as well.
Perfect. And then that was kind of a three-part question. So part two is, can pelvic floor muscle trigger points refer elsewhere and where?
They can. So trigger points can refer to low back region, down low by the sacrum and the tailbone. So if you're sitting upright and you touch right kind of between your bottom cheeks with your hand through that region, you can get an obturator trigger point that mimics kind of a proximal hamstring strain. So that pain high up in the back of the thigh, right kind of at the gluteal cleft, the gluteal fold, kind of right where your underwear sits. You can have some that refers pain more along in the front hip crease. So if you're sitting right where your front pockets are, there's a lot of different pain referral patterns. And a lot of times it surprises me how often people will come in and say, oh, my ovarian pain. And they're describing it as ovarian pain because it's abdominal but lateral. It's not central, it's not right next to the belly button. It's kind of out and over towards the sides where we think of our ovaries as being. I would say 95 out of 96 times when we get onto the deeper layer of the pelvic floor, they go, oh, that's my ovarian pain. So it can definitely refer pain to different places than just being more of that superficial pelvic floor region that we sit on. And then benefits and modalities to pelvic floor PT, such as ultrasound, TENS, biofeedback, and does RU use these? We don't have ultrasound, doesn't have as much of a direct benefit for pelvic health, but we do have TENS and biofeedback. We also have electrical stimulation. So things that can be helpful in terms of eliciting or tracking a pelvic floor muscle contraction, or that can be helpful with modulating the nerve-driven pain. So we have them, they're available. Some of our clinicians use them more than others, but they're definitely options that are available for us. And I can talk a little bit more on what is involved in each of those if somebody would like me to. Otherwise, I'll kind of leave it there so we can get to some other questions.
Yeah, well, we'll send a follow-up email, and if anybody has additional questions or follow-up about any of the things that we talked about, you guys can certainly respond to that email. But let me get to one more question. Let's see. Can scar tissue from abdominal surgery contribute to pelvic floor pain?
It definitely can. So we went back to that slide that showed kind of the torso, and it's in different colors. Depending on where the abdominal scar is, there's a lot of different things that can happen. There can be a nerve entrapment, meaning that a nerve gets stitched up when they're doing the wound closure. Depending on how big the wound is, it can change how you're moving through the trunk. The abdominal muscle sheath is continuous with our pelvic floor. So something that disrupts that fascia can lead to swelling or edema, more fluid in that area that puts pressure on the pelvic floor. If every time you lengthen it, it's uncomfortable, we can change our posture. Pressure management, depending on the type of scar, like C-section scars, if they're really, really bad, can adhere down to the uterus and the bladder and cause really a lot of discomfort for people in terms of filling for both of those ones, or even just friction. So with intercourse, there's kind of a thrusting motion that causes a shift in our pelvic organs. And for somebody that has an abdominal scar, every time something moves and shifts, it's going to be pulling at that scar. So it definitely can cause issues.
Perfect. Actually, everybody, thank you for your patience. I'm going to ask one more question just because I think this is a good piece of information for us to go over. And then after that, again, if anybody has additional questions, reach out to us. What's a typical length of treatment, number of visits, prognosis? What are some alternate conservative treatments if PT doesn't fully resolve symptoms?
Typical length of treatment in terms of like each individual treatment session, or in terms, so each typical treatment session is anywhere from 30 minutes to an hour, just depending on what we're working on. The number of treatment sessions varies wildly. I know we've had some patients that we see for 1 to 3 visits, and they're given more of a home exercise program. They want to work on things on their own and maybe want a few check-ins to see how things are going, but they prefer to do some things on their own. Other times I've had patients that I've seen for a couple of years. Sometimes it's continuous throughout that time. Sometimes it's an ebb and a flow if they're having a flare and symptoms resolve and then things come back. So it's really hard to say how many number of visits somebody needs. It also depends. The prognosis, again, is another really hard thing. It depends on how much work somebody wants to do to help manage things on their own versus how much they want to come into the clinic and have kind of this support and the assistance as they're going through things, and kind of the nature of their pain. That central nervous system upregulation with a lot of chronic pain comorbidities, PTSD, the ACEs, so that's a whole other topic for chronic pain, but categories of experiences that put our central nervous system at risk for being more sensitized are things that will be more challenging to treat over a shorter period of time and may benefit from a longer course of care.
Perfect, thanks, Whit. We've gotten a couple other questions, but we're going to go ahead and end it here. We'll send a follow-up email with answers to the questions that we've gotten. Just want to make sure that we let everybody go for dinner. We do have an event coming up this weekend on Saturday at 10 a.m. on swimming with the swim mechanic. So if you guys are interested in that, check out the website. Otherwise, thank you to everybody for joining us tonight. Thank you, Whitney, Sarah, and Beth Ann for the amazing session today on pelvic pain. And thank you to all of you guys for joining us today. And make sure to check out our other upcoming events on our website. Have a good night, everybody.
Great. Thank you, guys.